I'm Ann Geers. I used to be at Central Institute for the Deaf, and now I live in North Carolina, but I work out of University of Texas, Dallas. And my colleagues on this NIH project are Johanna Nicholas at Washington University and Emily Toby, who's at UT Dallas. This is not the CDACI cohort that John was talking about earlier. This is a separate sample, as you'll see pretty quickly. No financial relationships. Okay, we have a longitudinal design that's a little bit different than the kind John was talking about. Okay. I'm technologically challenged today. Okay, here we'll do it here. These are kids who were implanted between 12 and 36 months of age, so they're all early implant kids. We got a language sample from 76 of them when they were 3.5 years old, brought them back, got a language sample at 4.5 years of age, and then we didn't see them again until an average age of 10.5, when we got 60 of them to come back for these data research camps that we do. That's sort of our MO for a lot of the research we've done, and we run camps and bring kids in from all over the country for 3 or 4 days. And we test them and we entertain them and take them to Six Flags and stuff like that. So it's a lot of fun. So these kids are not from any one geographical location, 27 different states, 1 Canadian province, not representing any particular program. I'm going to be talking about those 60 kids who've completed the entire battery. 30 boys, 30 girls, just turned out that way. All deaf from birth, all in auditory oral education. We've looked at differences between auditory verbal and auditory oral, and we don't find any, so we put them all together, and they all come out of early but good option and auditory verbal settings. Implanted between 10 and 3 years, 2 months, 1998 to 2003. Half of them received a second implant, somewhere between 46 and 119 months of age. This gives you an idea how their education changed between 4 and 10. At age 4, 78% were in special education, usually at an option center. 12% were fully mainstreamed by that time, 2% partially mainstreamed, and 8% is what we're calling homeschool, which means they were still home with their moms, but with an auditory verbal therapist seeing them on a regular basis. By age 10, this had changed dramatically, and it has for a lot of these implant kids. Only 2% were in special education, 85% fully mainstreamed, 8% partially mainstreaming, and 5% were still being homeschooled with their mom. This is a select sample. It's not an unselected sample by any means. Most of these moms had a college education. We ask the moms at the follow-up camp about their communication mode. This is at a mean age of 10. The vast majority of these kids were rated as using speech with ease. A few used speech with difficulty, and 1 child used occasional sign. They wore their implant all day, every day. Very few, 2 kids, wore a hearing aid in the other ear. Their use of the device either increased or remained the same over this time period between 4 and 10 years. The benefit from the device was described as very useful in most of the cases. Now, this is a list of speech processors used at some point by kids in this study. In terms of generation of processor, this turns out to be important in several of the research studies we've done. This processor rating indicates what generation of processor it was. So at 3.5, The first implant that these kids had, 19 of the kids had an advanced bionics PSP, and then there was Med-Al Tempo. And you see 28 had a nucleus sprint. By the time, by the time they were 10, most of them had moved up to nucleus freedoms. And in their second device, most of them were using the most recent generation. Those are generation 4 processors. And I'm going to be referring back to that later. So I wanted to give you an idea that this is not a static thing that somebody receives a processor and stays the whole time with that particular device. So the first study, and this is the paper that you all got to read ahead of time, we're addressing the questions, do early implanted children reach normal language levels during the preschool years? Does performance improve, deteriorate, or remain constant relative to hearing age mates over time? And what factors contribute to successful outcomes? So I'm going to be showing you results on the preschool language scale at 4.5 and comparing them to self-scores at age 10.5, the composite score covering syntax and semantics and the various areas of language covered by these tests. Here's the normal standard score distribution that we would see from the normative sample with a mean of 100 and a standard deviation of 15. And this is the group that they're going to be compared with all the way through this presentation. And first we're going to look at what their score distribution looked like in relation to that sample in preschool. And we see a very skewed distribution with lots of scores here, more than 1 standard deviation below what is expected for 4.5-year-olds on the PLS. Actually, 68% of the cases are more than 1 standard deviation below this green bar, which represents minus 1 standard deviation from the mean. Now let's look and see what that same distribution for that same sample of children looks like at a mean age of 10. Very different kind of distribution. Here we see many more cases falling within the average range. Now only 32% of cases are more than 1 standard deviation below the mean. That's still more than we'd expect in the normal sample, where we'd expect 16% down there, 16 down here. But we have a much more normal configuration to this distribution. So kids are changing a lot between preschool and elementary grades after they get out of special education. Comparison of the two distributions, very negatively skewed and much more normal. Now, when we do a regression analysis and just consider results at 10 as a continuous variable and predict how well are they doing on the self at 10 and throw in lots of variables, the parent demographics and all the information that we collected, we come up with 3 variables that account for independent variance in performance at age 10. Age at implant, of course, is the biggie. Nonverbal intelligence, pre-implant aided pure tone average. Now there's kind of a reciprocal relationship between pre-implant pure tone average and age at implant, because kids implanted at 12 months are much deafer, or considerably have much higher aided thresholds than kids who were implanted closer to 36 months. So more hearing, that tend to put it off later. So you really see your dramatic age at implant effect when you factor out pre-implant hearing. Now, to look at how these scores change over time, this is the predicted regression coefficient based on age at implant, which is along the abscissa, plotted for kids when they are 4.5 and when they are 10. And what we can see is, what I've had indicated here at 4.5 is the age, implant age, the mean implant age at which the average score reaches 100, which reaches the normative mean. And you can see that only kids implanted around 13 months of age could be expected to reach that normative mean by the time they were 4.5 years of age. By 10.5, however, we've gone up. We're closer to 18 months, somewhere around 17 months of age, these kids. And the kids by 10.5 are staying all the way up to kids implanted by about 24 months, are still continuing to have an expected mean within the average range for their age. Again, displaying that there's a lot going on between preschool and elementary grades in terms of language growth. So that just sets the stage for what I really want to talk about, which is the language-delayed kids. But what we found was kids implanted at 1 to 2 years of age can be expected to complete elementary grades in a mainstream setting and achieve language scores that are within 1 standard deviation of their hearing age mates by the time they're in mid-elementary years. Doesn't mean they all do, but it means it could be an expectation for these kids. And the advantage of early implantation was maintained over time. Children with earliest ages of implantation, just as Dr. Naparko showed you, they continue to be the best performers. Now, this is the study that I'm more interested in sharing with you today, which is based on the same sample of 60 kids, where we're first looking at what proportion of these preschool language delays persist and what proportion resolve over time. So we can think of these in terms of 4 groups, and those of you who are in the SLI literature are pretty used to this sort of thing. We have kids who are delayed at 4.5, split into 2 groups, those who are within normal limits at 10 and those who are still delayed at 10. These are the ones we're calling persistent language delay, and we're calling these late language emergence. And then we have those kids who were already within normal limits at 4.5, and we can have 2 things happen there. They can either be within normal limits at 10, or they can have regressed and be delayed at 10. These are the normal language development group and the late emerging delay group. Here's the scores at 4.5, sort of replotted in terms of these groups. Here's the average range for normal hearing kids. And we see we've got this group here that we're going to call the normal language emergent group, and they're all scoring at 4.5, well within the range of where they should be scoring. But the rest of these kids are still below. So let's look at each individual subject now, plotted by their scores at 10 on the self. And we see that we only really have 3 groups here, and they're fairly equal in size. We have those kids who continue to be delayed. We have these late language emergence kids who were delayed at 4.5 but are now within the average range. And then we have our normal language emergence group who have stayed within the average range between 4 and 10. So we've got about 3 equal groups, which is nice for our statistics. And now we're going to begin to pull apart what factors differentiate groups of children with normal language emergence, late language emergence, and persistent delay. What we're most interested in, of course, is differentiating those kids with late language emergence from those kids with persistent delay. Because we can't tell the difference here when they're 4.5 from their language scores, and we'd like to know who's going to stay delayed and who's going to catch up. So I'm going to be showing you some slides. I'll go through this one so that when you look at them, they'll all be the same. These are looking at various characteristics of these 3 groups: the normal language emergence, the late language emergence, and the persistently delayed group. We're going to have an overall F and P to indicate whether that was a significant difference. And if one group is significantly better, it will be in red based on the post hoc comparisons. So you can see that when we look at age at first hearing aid, which also corresponds to age first educational intervention, they're very, very similar. The normal language emergent group got a hearing aid, got intervention, and got their first implant at a significantly younger age. But what's important to us is that this was not significant. For the kids who are delayed at 4, we can't tell from their age at implant, we can't tell their age at intervention, we can't tell from their age at hearing aid which ones are going to catch up and which ones are going to continue to be behind. Now, this is an interesting variable that did differentiate the groups. The percent of children who got their first implant in the left ear. I don't really understand this, but 47% of these kids with persistent delay, I don't know why this keeps going back, got their first implant in the left ear, compared to 13 and 21% in the other groups. Mother's education level, no difference among the 3 groups. Aided pure tone average pre-implant, no difference. Grade first mainstreamed, the normal language emergent group were mainstreamed significantly younger, but that's a result of their having normal language at 4, not probably a causal relation. Gender, no difference. If anything, it's a little odd that 63% of the persistently delayed group were female. It's kind of, but that's not a significant difference. So when we just look at these background characteristics, we don't see much differentiating these 2 language delayed groups, the one will catch up and the one that won't, except for this interesting statistic about left ear implant. Now, just to show you, because age at implant has been such a powerful variable in all of our research, how these 3 groups, I just had someone plot implant age in months for the normal language emergence, late language emergence, and persistent delay groups. And you can see that, yeah, it's true that normal language emergent group has a lot of kids who were implanted below 18 months of age. But for these 2 groups, age at implant tells us nothing about who's going to recover in language and who isn't. So I'm going to look back at what we had. Remember, we started testing them at 3.5. That was our first language measure. We did a parent-child conversational interaction, a 30-minute session, video recorded, with a standardized transcription of both language and speech sound production. And we had the parents fill out a CDI form. What we got from the child's analysis of the language sample was a number of different root words, mean length of utterance in words, number of bound morphemes, and number of different bound morphemes. What we got from the analysis of speech using Casala, which is another computer-generated system for matching each phoneme produced by the child with the target phoneme derived from the language sample for the first 100 words. We got a number of different vowel sounds, number of different consonant sounds, and Emily Tobey created something called a weighted developmental score, in which each sound is multiplied by the age at which it occurs in a normal hearing population. So sounds that are in the literature, usually the Templin norms as being present by 2-year-olds are multiplied by 2, etc. To give us sort of a weighted idea of what is the maturity of the speech sounds being produced by these kids. And then the CDI, as most of you know, just has as a parent rating, what vocabulary words have you heard your child produce more than once? And it has lists of words that they check off. They have a list of irregular words and ratings of sentence complexity. So it's a parent judgment. Here's the same kind of graph, but now we're looking at 3-year-old speech and language characteristics. Again, what you notice is there's lots of red for the NLE group. It's easy to separate out those kids who have normal language by preschool. They're better in everything. But there's not much. Certainly these early grammar measures we got from a language sample do not significantly differentiate our late language emergence and our persistent language delay groups. Neither do the CDI ratings. They're in the right direction, but the variability is so huge they don't reach significance. However, the early speech measures do. Here we see that the children who are going to recover, who are going to be normal by the time they're in elementary grades, started out with more different vowels, more different consonants, and a higher weighted developmental speech score. I'll tell you later what I think about this, but I'm not sure why this is the case. We measured lots of things at 10.5, but I'm going to tell you about some of those. Nonverbal intelligence, that's the WISP, perceptual reasoning. The duration of implant use by the time we did the follow-up testing. The kind of technology they were using, remember I told you that was going to come back to be important. Whether they used 2 implants or not. What was their cochlear implant aided pure tone average threshold? Just sort of an overall measure of audibility. How soft a sound could they hear? And a phoneme perception score on the lexical neighborhood test. So here, no difference in performance IQ. That's been a variable that really kind of helped us predict language in the past, but when we're talking about differentiating among these 3 groups, no significant difference. Duration of implant use at second test doesn't tell us much. Use of most recent technology, it is true that those kids with normal language emergence were upgraded. They had a much bigger tendency to use the most recent technology available at retest, where only 42% of those kids in the persistent language delay group had upgraded their processor. Bilateral device use did not get a significant chi-square, although the percentage using bilateral devices in the normal language emerging group was 63% compared to only 37% in the persistent delay group. Not significant. Here are the 2 variables that we measured at age 10 that did differentiate between these 2 groups. Their cochlear implant aided pure tone average threshold for the persistent language delay group was significantly higher. They just didn't hear as soft a sounds. They were responding at almost 27 dB, whereas those kids in the normal language emergent group were set closer to below 20 dB. Audiologists have not considered that to be so critical as I think we're beginning to think it is, to get the perception of soft speech. And finally, the LNT phoneme score, a speech recognition score, but we're not going here looking at word scores because that's so influenced by vocabulary. We're looking at phoneme scores. 94% correct in the normal language emergent group, compared to 78% for the persistently delayed group. So they're not hearing as well. It has to be louder in order for them to hear it, and then they're not perceiving as many phonemes, the persistently delayed kids. So if we look at the variables that we've examined, there's a different group of variables that differentiate the normal language emergence from the late language emergence, and the late language emergence from the persistent language delay. It's like these are different group comparisons. For the normal versus late language emergent groups, The normal language emergence were implanted at a younger age, so they got a better start. They have better early grammar, they have earlier mainstream placement, and they use more recent technology. So the kids who caught up by 4 had all of those characteristics compared to the kids who took longer to catch up. But look at the comparison, the factors that differentiated those with persistent delay from those with late emergence. Here the variables are totally different. Left ear implantation, less audibility for speech, poorer speech perception, and immature early speech production. Now, because there's so many auditory type variables here, I'm thinking maybe those early speech production differences had to do with audibility of speech, because little deaf kids tend to produce what they hear, and these kids weren't hearing as well. So we did a multinomial regression to look at the divisions among these 3 groups, and we did it in a stepwise fashion. First removing age at implant, then bilateral use, then most recent technology, ear first implanted, nonverbal intelligence, language at age 3.5, and then speech at age 3.5. And these were principal component scores that were created by combining those individual variables I told you about. What we wanted to see was the independent contribution of these variables. The tables I've showed you just previously looked at each variable independently. Now we'd like to see, if you throw them all together, which variables are coming out as being most important. And we're going to use the late language emergence group as the reference group in all of these cases. First, we're going to just compare the normal language emergence with late language emergence. And this just squeaks into being significant. Age at first implant and language principal component score at age 3 is what differentiates those 2 groups. Those who were normal when they're in preschool and those who catch up later. But when we look at what differentiates late language emergence from persistent delay, it's what ear they first got their implant in and what their speech was like when they were in age 3. So we've got different predictors. And just to give you an idea how different they look, this is the logistic regression lets us come up with the probability that for each child you can come up with a probability that this child is in PLD, LLE, and LE. So this is plotting age at implant against the probability of being green is normal language, red is late language, blue is persistent delay. And you see that with increasing age at implant, the probability that you would be in the normal language group descends precipitously. From about 60% probable if you're implanted at 12 months, down to a very improbable if you're implanted out here. But when we compare the same kind of probability plots for the late language group and the persistent delay group, you don't see age at implant giving us good discriminability between those 2 groups. It mostly gives us good discrimination of who's going to have very early catching up of language. We can use the same kind of analysis to look at, based on the 7 predictor variables that I just listed for you that were entered into the logistic regression. Based on all those, we can come up with a probability that a child is in that group, will score in that group, and compare it to what we observed. So for the kids that were observed to be in the normal language emergent group, 16, based on those 7 variables, were predicted to be in that group. But 3 of them were mistakenly predicted to be in the late language emergent group, for an overall percent correct of 84% correct prediction from those variables. Somewhat less when we're looking at the observed versus the predicted placement in the late language emergent group. 2 of them were mistakenly placed in normal language emergent, and 4 of them in persistent delay, for a 72%, almost 73% correct prediction. Now, this is still considerably improved over earlier. I showed you when we were just trying to predict the exact score at age 10. Looked at those 3 variables, age at implant, pure tone average, and IQ. We could predict 38% of the variance in that if we're trying to predict exact score. We can do much better if all we're trying to do is to predict what category you're going to be in. Our prediction rate goes up considerably. Predicting persistent language delay, we're right 13% of the time, we're wrong 5% of the time. But we never, based on those variables, call a child who is persistently delayed in the normal group. So in a way, as people who are dealing with kids clinically, we don't care so much whether to predict whether their score at age 10 is going to be 100 or 108. We just care whether they're going to catch up for a lot of the predictions we're trying to make. And finally, I want to talk a little bit about what are the academic consequences for these kids who are remain in this persistent delay group. One of the measures that we have used historically in deaf education to look at how well a deaf child is doing as he progresses academically is his verbal performance IQ gap. How close is that the performance IQ representing his potential, the verbal IQ representing the language impairment due to hearing loss? So how close is he to catching up? So we want to look and see what the size of that gap is. We'd like to look at phonological decoding skills for reading to see if they're at age-appropriate levels. And we'd like to look at reading comprehension skills. We use the Wechsler to look at the verbal performance gap and the Woodcock reading mastery test to look at basic skills through word identification and word attack, which is basically phonics. You're reading nonsense words and you're just looking at their phonics skills. And reading comprehension on the Woodcock looks at both word and passage comprehension. Much more involved with syntax, much more involved with the global aspects of language. Similar kind of graph. We've already seen that performance IQ doesn't differ significantly. But look at the size of the verbal performance gap in that persistently delayed group. Now, these gaps for the normal language emergence and the late language emergence group are very close to normal, which should be expected to be 0. And it is very rewarding to see that 2/3 of these kids by elementary grades have, for all practical purposes, closed that verbal performance gap. For those of you old enough to be in deaf education a long time, that's a pretty phenomenal thing. But this is what we used to see in the old days. 24-point verbal performance gaps, that's huge. And that's what we're still seeing in this persistently delayed group. Now, their basic skills, reading skills, are not different. I mean, yes, the normal language emergent group is very, very, very good. But between the late emergence group and the persistently delayed group, that's not a significant difference, and they're both within the average range. It is in comprehension that we're seeing the biggest consequences, and that's related to this verbal performance gap. These kids aren't living up to their potential, and they're not reading at their potential. in a way, it really is exasperating to see kids who in every other way have the advantages that these kids have that we see in so many kids in this group, and trying to understand why some kids just aren't getting there. And that leads us to thinking about language impairment. And this is just, we're just at the beginning of trying to explain why some of these kids are in the persistently delayed group. We still don't know, for example, whether some of them will close that gap as they gain experience. You know, we've seen them close the gap between 4 and 10. Are they done? Or if we look at them again at 12, 15, will that gap will they continue to improve? I suspect not, but we need to get those data. Does specific language impairment underlie PLD in some of these children? And how can we distinguish those kids with persistent delay that's due to some auditory phenomenon, left ear implant, bad thresholds, from those kids that it is due to some other mechanism associated with SLI? We know that the group is too big. It's 33% of this population, and we know that's too big to be SLI. But some portion of those we should be able to identify as having some specific language impairment. And we're interested in trying to follow up this idea that early speech production seems to be reflecting long-term language problems. And can we find a way to make that into a more reasonable assessment tool? Because if we know at 3.5 who's going to have problems, we can begin to develop intervention methods to address them. So that's where we are right now. And those of you who know a lot about specific language impairment in this room, you should know that we have looked at the natural things like digit span, novel word learning, non-word repetition. We've looked at a lot of those traditional measures. The problem is that they're very auditory related, and they tend to be deficient in both the late language group and the persistent delayed group. So they're not where we're going to find our diagnostic information. But thank you for listening to all this data. Thanks.
Well, please come forward.
I'm Uma Soman. I'm at Vanderbilt University. Thank you so much for this presentation. It's very nice to finally make sense of what I was seeing in the classroom, to kids doing well, to catching up, and to going nowhere. So thank you so much for creating these groups and sharing this with us. My question is related to the late language emergence children. Clearly, something clicked, something happened, they caught up. Do you think it is mostly related to the factors, or were there any specific interventions that you want to investigate further as potential contributors to this catching up?
Yeah, I wish we have looked. We have a lot of intervention information about these kids. It appears that they tended to go into the mainstream at first grade, the persistent delayed kids in second grade. There was a lot of variability, and you could not, based on when they entered the mainstream, you couldn't differentiate them. You couldn't differentiate them based on, now they all got started not as early as the normal language emergent group, okay? But you could look at those two groups, and when they got started and their oral programs didn't differ. Mm-hmm. When We looked at when they entered a preschool class, because Jean Moog and I have looked and seen in another study that those kids who were enrolled in a preschool special education oral class at 2 did better by 6 than those who were enrolled. That didn't do it for these kids, differentiating these groups. So the answer is, and they were all in good early oral intervention with very involved parents. So whatever it is, it's more subtle than that.
Sorry, can I ask one more question?
Sure.
You said the students went from 78% being in special education to 2% being in special education. So when they were in mainstream settings, did they still receive some form of special education services, or they were
Yes.
completely off IEPs?
No, most of them did, and we looked at the percentage of grades in which they had individual therapy, pulled out for individual therapy, and that went the other way. The persistent language delayed kids had more therapy. So of course they did, because they weren't doing well. We looked at whether they used FM systems. No difference. We looked at a lot of we're educators, so we could think long and hard about what would we ask, what would we want to know that we think might make a difference. And we just didn't find any.
Thank you.
Uh-huh.
Hi, Laura Dilley, Michigan State University. Thank you for a fascinating presentation. I wonder, to what extent do you feel the quantity or quality of speech-language input to the children might account for some of the variability that you're seeing in outcomes?
Well, that's hard to know for sure. We do have videotaped interchanges with the parent and the child. All these parents were in intervention programs and had been since they were very young, coaching them on interaction. And we have to remember that at 3.5, there was no difference in their language output. So I guess the answer is no, we didn't see those differences. Now, we did not, we do have a graduate student who's looking at the mother's input. And there, some preliminary results of that are that kids tend to have better language when the mother's input matches the child's grammatical level. So there's a point at which you can have too much talk. I'm looking at the progress between 3.5 and 4.5, and we're just charting which kids made the most progress. And when the mother's language grammatically matches the child's language, we saw significantly faster progress. Now, I'm not talking about differentiating between the late language emergence and persistent delay groups, but that is an observation, and we need to look more, I think, at that.
Hi, I'm Eileen Habig, and I'm at UW-Madison. My first question is, I'm sure you've looked at this, but for the language scores that you presented, the standard scores, they were based off of chronological age, right?
Yes.
So if you calculated a standard score using their hearing age, did you see anything with that, like especially with the late language emerging?
That would be kind of reflected in their duration of implant use, and that was just very similar across the groups. So, yeah, no, that wouldn't probably have done it.
Figured.
Yeah.
And then just from the last comment that you made about the maternal input, so you talked about the grammatical level of input, but you also looked at frequency, right, of different types of input?
Well, we looked at number of words, number of different words, number of bound morphemes, number of different morphemes, bound morphemes in MLU. Those were the variables that stood out as being, and we just did it for the parent output and the child output, and tried to look at how closely they were matched. And the closer the match, the better the progress, regardless of whether the children were at a low language level to begin with or a higher language level.
Thanks.
Really nice talk. So I'm Hope from Vanderbilt, and I have a question that may be silly. Why do you think the left ear was important? That just seems so weird.
Well, there's literature out there. It seemed pretty weird to me, too. There is literature out there with adults, implant patients, that shows better speech perception for right ear than left ear implants. There are 4 studies out there like that. But I have not seen any studies that show the effect on language. But we really need to replicate all of these results. And I'm talking to John about maybe replicating this with a different sample, a broader sample, because I just don't know whether this is a sporadic result. But, you know, there are people who might believe that there is some brain lateralization that is important for language that may be affected. I don't know.
So, I mean, it could go either way.
Yes.
So it could go either way, but it might be just a spurious statistical
thing. It might be
thing.
just a spurious thing.
Okay.
But I will say that nowadays, most surgeons, all else being equal, implant the right ear. So there's some evidence to indicate that there's a preference for the right ear, all other things being equal. But back in the day when implants first started, I remember when the surgeon would say to the parents, look, both ears are very similar. Which one would you like your child implanted in? I don't think that happens anymore, but that was a long time ago.
Thank you.
Hi, Reggie Saad from the University of Auckland, New Zealand. I just would like to know more about the Casala results because it's speech. So I wanted to know, did you analyze it according to place, manner, and voice, or you just in general? Because I noticed it's connected to speech sample, which is great.
Yes. Emily Toby is doing those more intricate analyses. So far, this is what showed significant differences, okay? It was just overall consonant correct scores. But we're talking about 3.5-year-old very deaf kids. So they don't have much, they don't have a lot of phonemes to begin with.
Yeah.
And so when she tried to break it down into the categories, I mean, Peter Blamey's program does let you break it down into all kinds of categories. There would be so few exemplars that it was very difficult to see significance. So no, we have not seen that, but she's still working on it.
Yeah, because I used Casala program and I'm doing my doctorate in it, and I know that there are some sounds, if you use it in comparison, like the results will come in comparison to the adult's production. It's not according to the child's phonetic inventory. So if you're looking at the child's phonetic inventory, you need to count it again, not inside, like not by the program itself.
Oh, you mean...
If you're looking at the phonetic inventory, not the percentage of consonant, correct, then you need to count it as the child by themselves as, you know, that's the child's speech, regardless if it's correct or wrong.
Oh, okay. Yes, but
Yeah.
there's 2 numbers you can get from there. One is a correctness score and one is just an occurrence.
Yeah.
Okay? We're using the correctness score because that is what gave us the significant differences.
All right. Another question is, it's really interesting that you put for the future, can speech production assessment give us more? My question for you, what about early speech intervention? Like early stimulation. For the sounds, we already know, like in majority, we say, oh, they have problems. I know as a speech language therapist, we don't really have now a specific kind of a speech therapy, evidence-based speech therapy approach that we can use. What do you think about that?
Well, speech and language are so intertwined, and in oral and in auditory verbal intervention, you know, you're putting in speech and trying to get out the best approximation that you can. But you're working on speech and language simultaneously. You're not working on speech sounds in isolation like you might do for an older or tic case, for example. And I don't see pulling those apart for intervention.
Oh, no, I still agree with you. We have both of them. But what I mean is like have more, like I know auditory verbal therapy, but it's not that much of concentration about the late acquired aid that we know that kids with hearing loss have problems with. My idea is that what about have what about developing a new evidence-based speech therapy approach, like based on the ones that have been already in the literature for children with speech disorder, and implemented beside the auditory verbal? That will help them out.
Well, it's an interesting idea. As young as 3, you think, these very young kids doing a articulation intervention approach. I don't know, I'd have to ask some of the teachers what they think about that. It's an interesting idea. Thanks.
Please introduce yourself. Hi, Caitlin Imgren from the University of Kansas.
Hi.
So I was very fascinated by your talk, so thank you so much. I'm wondering about the demographics of your participants. In particular, as you mentioned, the SES of this sample was quite a bit higher than what we would expect to see in the general population. And although it is very amazing that so many of these children were able to move into within normal limits, so your typical language emergence group, it did seem to me like perhaps given the fact that your SES was so high, if those children had not had hearing loss, we might expect their averages to be even a little bit higher than the normal distribution. So is it possible that even with these children who are moving to within normal limits, we're still not tapping into perhaps their true language potential? And if you could speak to that, that would be wonderful.
Yeah, you did notice that this normal language emergent group were getting kind of super normal scores on some things, up in the 120s, And that's largely because that's probably based on their environment, the average. And so, a kid who is doing 90 and functioning in some of the educational environments these kids are functioning in are operating with a handicap. Mm-hmm. They still belong in the mainstream setting. And I think those kids will continue to improve. That's why I'm so interested in this verbal performance gap, which is so huge for the persistent language delayed kid, because that just tells me how close they are to hitting what we could call their ceiling. And a lot of these kids are there. It's also important to remember that it was astonished me, because it was the first time I saw John present these latest data he has, and about a third of his kids are what I would call persistently language delayed. So even though we have very demographically different groups here, about the same proportion are in this persistently delayed group. So it's not just that kids in our sample are particularly advantaged. There's something about a third of these kids that we have to figure out. It's something we're doing, maybe, that we have to figure out.
Thank you.
Uh-huh.
Hi, Ann. Thank you very much. This is Debbie Moncrie from the University of Pittsburgh. And if you may remember, I focus on normal hearing children and auditory processing. And one of the areas that I have specialized in is the asymmetry between the 2 ears. And in the majority of the population, the asymmetry is shown as a left ear deficit. So we now have evidence electrophysiologically that in the weaker ear pathway, there is an increased gain in the neural signal. And that increased gain in the neural signal is possibly leading to the loss of synchronization and speech perception and clarity.
That's fascinating.
I know. Wow. I wasn't going to come up, and then you started to go into, is it us? I don't think it is you. I think I've seen you present before, and you came to Pittsburgh, and we've been, or we presented here actually together. This subgroup of your population has always intrigued me. And so I'm now doing some work at the DePaul School in Pittsburgh to start to look at this auditory processing phenomenon in children with hearing loss as well.
Yeah.
So it could actually be in the wiring. I think it's genetic. I don't think it's acquired, although I have colleagues who think it is. But I think it may be in the pathway, and that there may be something inherent that is preventing you from allowing those speech and language processes to be accessed.
Yeah, well, we'll have to talk about what kind of task we might use with kids.
I would love to talk to you about that, and Emily.
All right, thanks.
And last question.
Please introduce yourself.
I'm Susan Steinman from New York Eye and Ear. Thank you very much. I learned a lot today. So you mentioned early speech production as a potential predictor of later performance, and I was just curious about what other potential predictors you were interested in investigating. You mentioned verbal working memory not really being a good one, but whether it's nonverbal working memory or what else was there?
Well, the other biggie is auditory and maybe auditory processing. But I mean, I think I don't know where else to go with that. I mean, I've seen, okay, their phoneme perception isn't as good, their thresholds are higher. Does that mean that we need to really get after the audiologists with little kids and say, get those thresholds under 20, get them under 20, do whatever you have to do? And we do that. And that'll make a difference? Or is that just a symptom of an auditory processing problem that's causing them to have a higher thresholds and poorer phoneme perception? I don't know whether it's a cause or a result. So that's the other area that is a big predictor. And I think that maybe we're getting at early speech perception by looking at speech production. So maybe we can get them both if we get a good measure of production early on. Thanks.
Wonderful. Well, please, let's again thank both Dr. Ann Geers and Dr. John Naparko. Wonderful session. Thank you so much.